Hello and welcome to this webinar looking into role of hip strength and mobility in patellofemoral pain. And this talk will be specifically looking from a runner point of view. So one of the common things which I'm asked is how important is hip in the management of a very common condition, patellofemoral pain in runners. So we're going to explore the various aspects, how the contribution of hip could be extremely useful in the management of patellofemoral pain, specifically in the running population. Now, I don't have to remind you that the most common condition in running injuries is knee related. So if you look at running injuries, nearly 40 to 50% are related to the knee. So conditions like patellofemoral pain, ITB, meniscal, flat pad, and the number one of the knee is patellofemoral pain. So if you're going to deal with runners, there's a high probability that you're going to see a lot of this patient with patellofemoral pain. Historically, it sort of was thought that most are self-limiting. That's something which gets better with time. Now, recent studies have shown that a large proportion of patients report chronic knee pain at long-term follow-up at 2 years, 3 years, 5 years, and even 8 years and longer. So this sort of multiple data from 2 RCTs have shown that more than 50% of patellofemoral patients report an unfavorable recovery even 5 to 8 years after recruitment. So that remains an extremely clinical challenge in an active population. So I guess it's the nature of the condition, it's multifactorial, and also you have multiple subgroups in that. So this is something which we have to be aware of, that although it's extremely common, it doesn't mean that it's easy to treat. So we need to have different tools, and we need to explore from all the areas, from your training load, history, proximal factors, local factors, distal factors. So it's finding what works for the patient. So it's having that sort of tailored approach which is going to be beneficial than having a similar approach for all patients. So if you want to get better outcomes, it's trying to be targeted and also specific to that individual, and also based on the requirements. Now, if we go to the role of hip strength, so hip strength, so for the next few slides, let's look into how can hip strengthening help in a patient with patellofemoral pain. A lot of studies have looked in the last 10 years. So we're going to look into various studies. I'm going to pick up 1 RCTs and 2 systematic review to look how hip strengthening can be useful in patellofemoral pain. Now, generally when we talk about hip strengthening is something you would use a lot in most cases with lower limb. So if you're dealing with the lower limb rehab, it's extremely likely that you're going to be dealing with hip strengthening exercises. For example, if you're dealing with low back pain, SIJ pain, there might be a role for hip abductor strengthening. There is a close relationship with the low back pain and gluteal tendinopathy. So a lot of patients will have both. So you're going to look into strengthening, and hip strengthening is used in pretty much most knee symptoms, from a simple ACL conservatively or surgically, from ITB, patellofemoral pain syndrome, and osteoarthritis. And definitely it has got a very important role in hip pain, such as your traditional hip osteoarthritis, hip impingement, and GTPS syndrome. And when you talk about even ankle instability, chronic ankle instability, we need to get proximal stability as well. So there's a lot of sort of role for including that in the end stage of ankle pain and instability. And when you're looking into power sports, as we know, as we run faster, the load of the muscles is pushed more proximally. So more from the calf, it's more pushed towards your hips. So if you want to really be good at your sprinting, pivoting, cutting sports, you need to really have good hip strength. So I think I don't have to convince you that hip strengthening is very important for both rehab and also for improving gains and explosive power in athletic population as well. So it's a paramount role for physios to include hip strengthening in most of our rehab patients. So let's start with some evidence here. So this is a great level 1 article here, and what it's shown here is that one of the first RCTs comparing benefit of hip and core versus knee. So this 4-year study was done across 4 centers, well designed multi-center trial, both men and women. Average age is 29, which is sort of similar group I see in runners, sort of 20s and 30s. The rehab was for 6 weeks. Both groups had improvement in function and strength. But what they found out was the hip protocol, the patients who started with hip and trunk stability had early resolution of pain and better outcomes. So it seems like if you start with initial stages, if it's painful, start with the hips. Once the pain is settled, then start loading the knee. So we got level 1 evidence saying that strengthening of the hip and core is superior than knee. I'm not at all trying to dispute the importance of quad strengthening. Quad strengthening is extremely important, but it's all about the timing and the stage of the symptoms. So if you got somebody who's very irritable, you can't load the knee, then it makes sense to start loading the more proximal structures, and which will have a big effect on your mechanics and also help you in your loading profile as well. So highest form of evidence, and the best is multi-centered. So this is just not done in one center, and very decent numbers. We're talking about 200 patients. Extremely difficult to do that in the real world, especially trying to get that adherence. So the authors have done a fantastic job here trying to do that and show us that definitely it's very useful. And when we put in a lot of studies together, when you look at systematic reviews, so systematic reviews concise all your RCTs and other studies. So when you look at this Nishimoto study in 2017, again we got a level 1 evidence showing that hip and knee strengthening is more effective than knee strengthening alone for decreasing pain and increasing activity in patellofemoral pain. So I think from a patient point of view, the number one role for me when I deal with this is sort of getting the pain under control. So that's the main important element, is get the pain under control before we start loading the quads and we are doing plyometric activities. And this is a good clinical prediction rule, which shows that the patient with patellofemoral pain who have more baseline pain and yet maintain a high level of function may experience additional benefit from a hip and core. So I think people who have high levels of pain, it's totally sensible to start with hip strengthening, which makes sense because you don't want to irritate the patient with the symptoms and make them more painful. So definitely I think we got the highest form of evidence there to support us. A recent one which has sort of come out from Simon Lack and group, Christine Barton, Dylan Morrissey from London, and so they looked into proximal muscle rehabilitation, systematic review. They looked at 14 studies, 7 of very high quality, and what is very clear is again the same results. So strong evidence to include proximal stability in the management of patellofemoral pain. So again the results match the previous RCT which I discussed earlier. So that's something which we have overwhelming evidence that eventually you're going to start with proximal rehabilitation, but at a later stage you're going to include both proximal and also quad strengthening. So it's all about the priority and based on the symptoms as well. One of the things which is ignored in many rehabilitation program is improving the power development, is improving a rate of force development. So obviously you might start with isometric, isotonic exercises, concentric or eccentric, but eventually, because when we talk about any sporting activity including running, there is importance of improving rate of force development, because things happen fast, and patients running is not done slow, and many of them will do other sports as well. So when we look into this study from Nunes, where they compared 27 with patellofemoral pain, they looked at hip muscle isometric strength and rate of force development, and what they found out was there is definitely impairment in force development in females with patellofemoral pain. So showing that just restoring concentric or eccentric strength is not enough. It's power exercises should really be important. So at a later stage you want to be doing some power based training, which is really important to get that full function, getting them back to, when we know that when you have pain and injury, you're going to have that effect on your rate of force development as well. So that sort of again shows us how from your rehab progression you might start from proximal for pain levels, and then you might include the quads, and then you might go into heavy slow resistance, and then before you go into plyometrics you might do some fast activities. It could be fast concentric, fast eccentric, to do it could be simple single leg sit to stand done at a fast pace, which could be improving your rate of force development. So I think it's looking into the whole spectrum of your treatment and just not looking at one element of loading. So the patient should be exposed to all forms of loading, so that they're fully both the neural system and the muscle system is well primed for the demands of running and other sporting activities. So clearly we got good evidence to show that hip strengthening has a valid role in the management of patellofemoral pain. So the next point would be is to look from a mobility point of view. So how about hip mobility? How does that affect? So that sometimes I'll be in the next few slides I'll be focusing mainly on the hip mobility aspect of things as well. So let's look that into detail. So this study looked at 30 patients with patellofemoral pain and 30 controls, average age around 34, and they looked at hip mobility in all direction. It was measured using a digital inclinometer, which is a bit more reliable than just your normal visual testing. And what they found was there was a significant difference in hip extension in subjects with patellofemoral pain. So that's really quite important. I think we should be careful not to say that hip extension, lack of hip extension, leads to patellofemoral pain, but it could be maybe it's a chicken and egg. Maybe we don't know what comes first. But definitely improving hip extension, especially I see a lot of runners in the male runners in the 40s and 50s. They might be getting a bit of capsular tightness. So there might be a role. If you feel like you're not getting hip extension, then you'll have issues with recruiting your glutes and stabilizing your proximal element, and that could have an effect on your knee. So it makes biomechanical sense is you can only recruit muscle strength if you have good mobility. If you have restriction in your mobility of hips, especially a very powerful movement like hip extension, which is very crucial for running, and if you got only 5 degrees rather than 10 or 15 degrees, you're going to have difficulty in generating the force. And if you don't generate the force, especially in your toe off, then you don't get the recoil. So I think it makes total sense is to look at hip extension, which is a fundamental element. Like if you look at mobility point of view, one of the two areas which I look into is hip extension and big toe extension. Really important for your push off, get that force generation and the propulsion phase. So if you have restriction in your hip extension, big toe, you will not likely to generate force. So that's a really important point to remember is trying to get that hip mobility. So hip mobility definitely has an important place to assess, especially in patients with patellofemoral pain. So this is more likely your middle-aged male patients who are more likely to lose. We know that hip mobility loss is more common in men as they get older, or with pathology. So if they're getting osteoarthritis or they're having hip impingement, they might have restrictions. So always good idea to check those. Now, common test which is used is the Thomas test. So I still use it, but we have to remember, some would argue that Thomas test is not the best way to assess, because the problem is we're looking at a combined movement here. So the static hip flexibility using the Thomas test is not reflective of your dynamic movements which happens in running. So what they look into here is it's a coordinated movement as well. So this study from Schalke, which is published quite a long time, 20 years ago, shows that the looking at just on the couch, you might have a fantastic hip extension on the couch, doesn't mean that you're going to use in running. So I think you have to assess them in different planes. So you might start them on the couch, then you might do a lunge test, like a reverse lunge or a backward lunge, and then you might see them on a treadmill. So just because you got fantastic movements on the couch doesn't mean like you're going to have excellent hip extension in running. So it's the way how we coordinate. So hip extension is a coordinated movement between your pelvis and the hip and the SIJ movement. So pelvic tilt and hip extension and coordinated movements. So always be, I'm not saying not to do Thomas test. It's a good initial assessment, but that doesn't really reflect how a patient runs. So we can't assume how somebody runs just because they have excellent hip extension running. Doesn't always mean that they're going to have also similar hip extension in running as well. So this is really important as well. So there's a lot of factors where it could be a poor stability issue, where so if you don't have good stability around your core and your lumbar spine, your body might not want that full hip extension and put more strain. So it's that body works together as one unit. So If you have pain, if you have apprehension, if you have some pathology, you might not necessarily use that full hip extension. So always look at the lumbar spine, the hip and the pelvis as one unit rather than individual units as well. And the key thing is, okay, let's do some manual therapy, let's improve your hip extension, let's do on the couch, let's pull your hips, let's do some manual therapy on improving hip extension. So that might be something which might be useful, especially with repeated hip extension. But what we see from other studies, like this is study from Stuart McGill group from Canada. So they looked at 24 healthy young men with limited hip mobility. So they had stiff hip, and they did a lot of hands-on treatment to improve hip extension. And what they found out was improving hip extension doesn't always mean that they're going to improve in tasks. So it doesn't mean like it's going to translate to walking, running, and jumping and other activities. So you might start with some hands-on treatment on the couch in a non-functional position, but then you might want to transfer that into more mobility drills in standing. So you might give some running drills to improve hip extension. So you have to retrain the body and the brain to sort of accept that new mobility. So just because you give more mobility on the bed, but doesn't mean like your body is going to accept it and start using it. So one is giving a range and another is using the range, entirely two different things. So what the author says is we should be giving active exercises, dynamic exercises to groove new motor patterns. It's like a mobility based training. So I think the body will shut down any movement it can't control or it's not trained. So we might regain passive movements first from manual therapy, but you need to have some active mobility drills to get that. So important thing is flexibility is always task specific. So how you test flexibility doesn't always mean that you're going to use in a particular task as well. So that's something always to remember is obviously hip extension is really important, but you have to restore them in an active fashion rather than just a purely passive way. So that is about hip extension. Another important element from a hip mobility point of view I like to explore is internal rotation, especially from excessive internal rotation, which could be an issue in female population. So I think we had this sort of historical view of just tracking of the patella. Now we know it's not the patella, it's the femur which is moving from the top, which has a bigger effect on the tracking. So it seems like if you have poor hip control, you will have excessive mole tracking. So this is an area which is getting investigated more and more, especially in female runners, is having excessive internal rotation. They might be antiverted, they have like 50, 60, 70 degrees of internal rotation. So normally you're talking about 20 to 30 or 40 degrees. So when you have excessive internal rotation, your body has to work harder. So it could be a structural factors, they are shaped like that, or it could be a control. So they looked at 15 females with patellofemoral pain versus 15 pain-free females between the ages of 18 and 45. So when they looked at kinematic imaging of the patellofemoral thing, they looked at a single leg squat. When you have altered patellofemoral joint kinematics, it seems to be linked with excessive internal rotation as opposed to lateral patellar rotation. So I think the control of hip internal rotation may be very important in controlling normal patellofemoral joint kinematics. So it's not about the patella. The way the patella moves tracks is very determined on how the rotation of the femur is controlled. So if you don't have a good proximal control, so that's why getting the proximal control is really important before you start loading the quads. So quads might help you in that sort of reducing the load on the knee, but the tracking of the kneecap is highly dependent on the stability. So giving good strengthening on the abductors, external rotators, and teaching them to control during functional task can be very effective to help us to sort of do that as well. So and you know, this is sort of is continued, this theme is continued with the next study which I'll be going through. So they looked at 9 females with patellofemoral pain with squatting, and what they found it was females with patellofemoral pain syndrome, patellofemoral pain, who exhibit altered hip kinematics, poor control, are putting a lot of strain on the patellofemoral joint. So I think if you don't have that control of the internal rotation, you are leading to excessive strain on the patellofemoral joint, which could be potentially one of the factors which could be leading to their ongoing symptoms as well. So I think from a lot of research in this area, it seems the control issue seems to be more in a female runner. So again, we need to be careful of using this information for every patient who walks in the door. It might not be appropriate for an experienced runner or a male runner, but for a young female who is also hypermobile or excessive range, it could be relevant as well. So again, looking into the age, the gender, and the experience of running, all those are important. So every runner is different in this aspect. So one could be a 5K runner, one could be a half marathon, and one could be overweight. So we need to really be aware of how they move and their natural way they do things. So especially in a female runner with patellofemoral pain, it makes sense to look at how they're controlling from the proximal elements as well. And obviously, exercise is the core strategy of management of patellofemoral pain. But in the initial stages, there is some good evidence of using taping as an adjunct to retrain the pattern. So this is a study from Song and et al. From 2015. They looked at application of femoral rotation versus sham tapes, reduced pain. So what they did was they did femoral rotation tape as shown in the picture. And that altered the way they move and reduce the pain. So they looked at 16 participants with patellofemoral pain versus 8 healthy controls. They looked at 3D patellokinematics measured by electromagnetic tracking systems, muscle activation by EMG, and what they found out was the subjective report of pain was decreased during single leg squat in 3 randomized condition. So what we have is there is an evidence of reduction of pain by changing movement. This is very, very, very useful information for therapists. So verbal cues, visual cues, kinesthetic cues. So if we can change how they move, that can have a big effect on the symptoms, and then we can start loading them. So I'm not disputing that loading is very important, but initially 100% of my patients who come to me is because of pain. So we want to control the pain, and we can use all the tools we have to help them to move better, have less pain. That can only help them to get their body back to the natural way. So I think we have to be careful when you use adjuncts to say that it doesn't fix the problem. It's just more to remind them. So the way when I give taping, I explain to them it's more like feedback proprioception, and it also helps the body to move in that appropriate strategy. So it's more like recruitment and strategy rather than supporting. I don't think a piece of tape can support your whole limb, and again, it's not a long-term strategy. So once the pain is controlled, we want to wean them off from this adjunct. So we don't want to create dependence on this sort of devices, because that's not very healthy for the patient in the long term. So I think definitely in the initial 4 to 6 weeks, or when they're getting back to running, I can see the use, or if they're having a flare up, it might be extremely useful to have that sort of adjunct as well. So in conclusion, we can't ignore the importance of hip mechanics, both from a mobility and strength point of view, in the management of patellofemoral pain syndrome. So first, when we talk about strength point of view, there is high quality level 1 multi-centered RCTs, 14 trials, 2 systematic reviews. So we're getting the highest form of evidence here. So what we know from this research is getting that sort of proximal stability is really crucial for getting that sort of pain under control, and we know that that is more useful than the quad strengthening, especially in that initial stages as well. So we want to really reinforce that it's more during the initial stages, and then we might include other stuff, and then at a later stage we want to include more faster exercise to increase rate of force development before going into plyometrics. So it's all about the progression. You start with the low level and then push them all the way to fast exercises. And when we talk about mobility, there are 2 issues here. One, in a small group of patient, lack of hip extension. So clinically I find that usually older men, 50 plus, 60 plus, who have some issues with early signs of hip OA, they lack hip extension and they usually come with back pain, and the recruitment of the glutes can be difficult. So you might use some manual therapy or give them some mobility drills to improve the hip extension, or cue them, and that can help them to better recruitment and to stabilize the hips. In young females, it's a different problem. It's not lack of movement, it's excessive movement. So when we look into internal rotation, controlling the hip internal rotation is very important for the position of the patella. The patella tracking depends highly on the control of the internal rotation of the femur. So again, you might look into stability exercise, get that control, and then we might start doing more load-based training. And when you look at hip mobility, we need to look into more passive as well as more active form of testing, and even on the gait. So you might see them on the Thomas test, progress them into a lunge test, and then see them on the treadmill. So we want to see how they're actually using the hips in different facets, because your brain will only use what it's used to and what it's trained. So just because you got amazing range on the couch doesn't mean like you're going to use that. So I think, based on the evidence and from a clinical experience, there is no doubt assessment of proximal mechanics is a very important part of the management of patellofemoral pain, and we have to look at both elements, both from the strength point of view as well as from a mobility. So that concludes my talk on the role of hip strength as well as mobility in the management of patellofemoral pain, especially from a runner specific point of view. Thank you.